Hi, welcome back to IU Radiology Case of the Day. My name is Nick Kuntz, and I'm a neuroradiologist and head and neck imager at Indiana University School of Medicine, and I'm back with another interesting spine imaging case of the day. Let me first start out by saying that all of the educational content found within this talk has been completely de-identified in order to protect patient privacy. So I'm going to obfuscate the actual clinical history just a little bit for this case because I want it to make it a little bit of a challenge and I want you to think through things. So this one goes out to Rick Wiggins. This patient presented with lumbago, the forbidden dance. So this is a pretty generic indication. Patient showed up with back pain, something we see all the time, and truth be told, this patient was having back pain, and that was why they were imaged, but there's something else going on. So let me show you the imaging, and I want you to try to put that together. So just two images to look at today. Image on the left is a coronal T2 weighted image. The image on the right is a sagittal stir image. So take a look, figure out what you think might be happening here with this patient. Okay, so all right, let's look at the imaging. So the first thing we have to look at is this coronal T2 weighted image. And the first thing you'll notice is that there's some mild dextroscoliosis, denoted here by the yellow arrow. It's sort of centered at the mid-lumbar levels. But what should really jump out at you is this patient has very marked dural ectasia. Their thecal sac is really ballooned up tremendously. It almost looks like a Christmas tree kind of appearance with this undulating dural ectasia. Now, if you look even more carefully, you'll see that there are multiple paraspinal and pelvic masses denoted by these yellow arrows. So whenever we see a mass or something out of the ordinary, we want to look at it in multiple planes, multiple pulse sequences on MRI. So let's take a look at our sagittal stir imaging. And again, we see that there's this marked dural ectasia resulting in scalloping of the posterior vertebral bodies, denoted here by the yellow arrow. And if you look at the alignment, it's abnormal in this projection as well. There's near spondyloptosis in this patient, and that is a result directly of the dural ectasia that's remodeled the lumbosacral junction, but the lumbar spine has almost completely slipped forward off of the sacrum. And then again, we see these multiple paraspinal and pelvic masses, denoted here by the yellow arrows. They're largely T2 bright, a little bit heterogeneous in their signal intensity. So let's put it all together. Patient has marked dural ectasia. They've got this abnormal curvature to their spine, and they have multiple paraspinal and pelvic masses. What do you think's going on here? So this is a patient who has neurofibromatosis type 1 or NF1. And this is a phacomatosis. It's characterized chiefly by multiple neurofibromas, but there's lots of other imaging findings and clinical manifestations in these patients. They oftentimes have waxing and waning white matter lesions, particularly in the pediatric population. They can have sundry gliomas, anywhere ranging from the optic pathway to the brain down to the spine. They have many different varieties of vascular and skeletal dysplasias. And if you look at their skin, they have these hyperpigmented macules on their skin, something you might see if you're doing interventional radiology or perhaps doing some sort of a radiology subspecialty that has you face-to-face with patients. This is caused by an autosomal dominant mutation of the NF1 gene, and it's much more common than its cousin neurofibromatosis type 2. Now, I use the term cousin loosely because, truth be told, they're really nothing alike. The tumors are completely different, but they're considered within this category of phacomatoses as both being neurofibromatosis. But at any rate, NF1 has an incidence of about 1 in 3,000. That's compared to NF2 that has an incidence of about 1 in 25 to 1 in 30,000, so at least tenfold more common than NF2. And importantly, this is a diagnosis of the first decade of life. In fact, it's thought that around 97% of patients who have NF1 meet diagnostic criteria by age 8. So what are the specific spine manifestations of NF1? Well, they have curvature issues with their spine. Commonly, they have kyphoscoliosis. They also have, because it's NF1, nerve root tumors, and these can be spinal, paraspinal, or extraspinal. So it's one of those diagnoses you really Obviously, you need to look at the spine and the surrounding soft tissues, but it's kind of a four corners of the film sort of clinical history that you really need to be looking for additional findings. They may have plexiform neurofibromas, which are much more larger conglomerate neurofibromas, sort of classically described as a bag of worms appearance. And interestingly, patients that have NF1 and plexiform neurofibromas are much more likely to have abnormal spinal curvature. These patients can also have cord tumors, as I stated before. They can have gliomas. Cord tumors are a bit uncommon, but something that certainly can be seen in NF1 patients. And as this case nicely points out, they can have dural ectasia. Sometimes it's very mild, sometimes it's very profound, like in this. It's sort of a spectrum. Closely related to that, NF1 patients may have lateral meningoceles as well. And depending on whether or not they have sizable nerve root tumors, or even if they have significant scoliosis, these patients may very frequently have cord compression. So it's important for you to be looking for and to report. There's a nice paper published by Wen and colleagues in the Journal of Neuro-Oncology in 20. Okay, so let's wrap this up. This is a case of NF1 involving the spine, and the key imaging features in this case are the marked dural ectasia, this abnormal curvature of the spine. This patient here had scoliosis as well as near spondylotiosis at the lumbosacral junction. And they also had multiple paraspinal and pelvic masses, which in this case were multiple neurofibromas. A couple of pitfalls to keep in mind. I think that age can be a very helpful discriminator when you approach these NF1 versus NF2 versus schwannomatosis patients. It's something that I like to teach our residents here. And that's because, as I said before, about 97%, so virtually all patients who have NF1 will meet diagnostic criteria by the age of 8. So it's really a diagnosis of the first decade of life. NF2 patients, the mean age of diagnosis is somewhere between ages 17 and 24. So you can kind of think of that as a second decade of life diagnosis. And then schwannomatosis, most of the time these patients aren't diagnosed until after age 30. So age, again, can be helpful whenever you're seeing these patients with multiple nerve sheath tumors to try to determine, hey, are we dealing with NF1 versus NF2 versus schwannomatosis? Lastly, a really important concept to bear in mind is that somewhere around 10% of patients with NF1 will develop a malignant nerve sheath tumor. So this is really important. It certainly necessitates vigilant surveillance of these patients with routine MR imaging. And what you want to be looking out for are neurofibromas that start to grow rapidly. Or clinically, they may present with new neurological deficits or really painful tumors. Those are things that can help you out. And so again, it's really important. You can sort of get lulled to sleep of looking at multiple follow-up studies on these patients. It's important to keep in mind, what's the growth pattern doing? Is it demonstrating accelerated growth? And if so, that's something that you want to keep in mind, could be a suspicious finding. Well, as always, thanks for tuning in to IU Radiology Case of the Day. I would invite you to follow along on Twitter at NAKuntz, and you can check out our complete collection of IU Radiology Case of the Day materials, which can be found at radtf.iuhealth.org/COTD. Thanks so much.